Shin, the word is yours. You can start, my friend.
Hi, hello everyone. Thank you for joining World Aphakia course. This course has a wonderful lectures from all over the world. Surprisingly, over 2,000 of legislation. There are over 2,000 legislation for this course. So please enjoy this course. Thank you.
Hello, guys. Pleasure for us to be here with these amazing speakers from around the world. I'm sure we will enjoy it. And let's go to Ashwin. Ashwin, you the guy that speak better.
No. Guys, every once in a while, there comes an event that at least we believe that just makes sense. This probably is one such event. It's been curated with some of the best in the world with the aim that covers a blanket over a topic that has eluded many of us. Honestly speaking, it's eluded, and I think probably it still eludes a lot of us in many ways, Aphakia. So here we present to you the World Aphakia course that hopefully puts things to perspective and gives you all a flavor of what's really all around the world that people are doing, currently practicing in their practices, and that works, at least in their hand, and many more. So some of the ground rules for this webinar and this course is we love to get questions and we love to answer those questions. They may not be wildly wise questions, but they might be very simple questions, yet a question like a phone call needs to be answered. So just guys, put in your questions on the website. You can see our course on worldwcrs.com or on the YouTube channels of Dr. Sergio Canabrava or Dr. Agarwal's Clinical Education. Any one of these, go ahead, click on and view. You can also share those wherever you need to. Without wasting any more of your time or the faculty's time, I wanted to also take this opportunity to introduce to you our first course, our first session, Basics in Anterior Vitrectomy. And to do the moderation for this course, I couldn't find or think of better names than Namrata Sharma, Naveen Rao, and a special panelist, George Beiko. So I'm handing off to them by starting off this one video. So can we have the video, please?
Thank you, Ashwin. It's my pleasure to co-moderate this course with Dr. Namrata Sharma, and I've been looking forward to this for several months now. I think it'll be a wonderful session and wonderful day. I wanted to introduce our first speaker, Dr. Rohit Prakash from the Prakash Eye Institute in Amritsar, India, and he'll be discussing signs of posterior capsule rupture. So let's begin our first talk.
Thank you, Naveen. Dr. Naveen, I would be talking about signs of posterior capsule rupture. Is my screen visible and am I audible? Yeah. I would like to thank Ashwin for organizing such a beautiful course. So I would be speaking about signs of posterior capsule rupture. So these signs of posterior capsule rupture, the first thing which we have to realize is that the biggest complication which we dread in a cataract surgery is a posterior capsule rupture. The classical signs of posterior capsule rupture include sudden deepening of the anterior chamber. When you're doing phacoemulsification, you find that the chamber has deepened, and pupillary snap sign. Suddenly you find that there is a sudden jerky pupillary constriction, during hydrodissection. And there's a transitory increased red glow, more so in the periphery. And when you are doing phaco, you realize there is a decreased followability, inability to rotate, sculpt, and bury the phaco needle. And at the same time, there's a nuclear tilt. So posterior capsule rupture can occur when the bag is intact or when there can be a zonulopathy. If there's a zonulopathy, we'll be talking about it shortly. Posterior capsule rupture with an intact capsular bag can be because in the presence of maybe an intact capsular axis, wherein we can use a sulcus fixated IOL and that clinches the issue. But whenever there is an anterior capsular tear, then this whole webinar is all about anterior capsular tear and zonulopathy and the posterior capsule rupture associated with. So this anterior capsular tear can occur in primarily every surgeon's hand. So we are at a crossroad of surgical dilemma, whether to continue with the plan A of converting to extracapsular surgery or to continue with phacoemulsification. So the next thing is, because in these cases, what happens is the phacoemulsification can be continued successfully without any problem, but there are times when we end up with a nucleus drop. So these are the main glitches which we come across. So what is the answer to this surgical dilemma? The answer lies in either we should know about the flap motility sign and we go on with the safe surgical techniques. Well, what is this flap motility sign? This is the sign for posterior capsule rupture in peripherally extended anterior capsular tears. What is the concept of flap motility sign? Well, the concept is if the flap is everted and fluttering, it is pre-equatorial by all means. And if by any chance it extends on to the posterior capsule, then it becomes flat and it becomes inverted. So this is the basic concept of flap motility sign. So what is there is, if the flap, as you can see in an anterior capsular tear, the moment you introduce the visco, this flap has become everted and it has started fluttering the moment you introduce the fluidics. So once you see that the flap is everted and fluttering, this is conclusive of the fact that it is pre-equatorial and you can continue with safe surgical phaco techniques and without any problem of yours facing the situation of a posterior capsule rupture. You will find that even when you are doing IA, this flap is everted and it is fluttering. And even when you implant an intraocular lens, the flap is everted and fluttering. So my dear friends, when you find it is everted and fluttering, you can continue and put an intraocular lens in the bag without any risk whatsoever. So in this case, I would like to show that the fellow resident who was trying to enlarge the rhexis ended up in a situation where the rhexis extended onto the periphery. So when it extended onto the periphery, he continued with phacoemulsification. And the moment he divided, you will find now at this point of time, the flap has stopped fluttering and it has become flat. So this shows that it has extended beyond, and the fellow, oblivious of the relevance of flap motility sign, continued, and there was a nucleus drop which happened as it would have in this situation. So with this application of flap motility sign, we come to know of the end point of safe phacoemulsification. That is the point when you can avoid the dreadful complications of posterior capsule rupture the moment it stops fluttering. The relevance of this flap motility sign is that it helps us to implant the intraocular lens in the bag. So if the flaps are inverted, this means now you have to do other things, and this is what the whole course is going to be all about. Thank you very much for your kind attention.
Thank you, Dr. Rohit. Excellent talk. I think that I've personally found that very useful when we have an anterior tear. George, do you find this to be helpful for not just anterior capsule tears, but what kind of signs would you look for if there was, let's say, an equatorial capsule tear, to know if there's vitreous or if you can stop phacoing or continue? You may have to unmute.
Sorry about that. You were asking about an equatorial tear?
Right. Sometimes we have an equatorial tear, but sometimes it's an anterior capsular tear. How would you know, if you need to stop phacoing or continue phacoing if you have a situation where there's a tear either in the edge of the rexus or just beyond the edge of the rexus?
I think Rohit's video and Rohit's sign is very important for us. I mean, I think this is a good thing for beginning surgeons to realize that this sign is helpful. And I find that whenever I have an anterior capsular tear and I'm worried that it has extended beyond the equator, I stop doing the phaco within the bag. I will try and bring the pieces out into the anterior chamber and isolate them with viscoelastic. If I'm really worried about a huge tear, I'll do the scaffold technique, in which I'll bring in the IOL and place it underneath the pieces, and then do phacoemulsify the pieces in the anterior chamber and examine the capsule afterwards. So I think the important thing is to try and prevent those pieces from falling back into the vitreous cavity.
Thank you. Dr. Namrata, would you like to introduce our next speaker?
So it is, first of all, I would like to thank Shin, Ashwin, and Sergio for this wonderful course. And it is my pleasure to introduce the next speaker, with whom I have done a couple of courses on keratoplasty, Dr. Yuri Mckee from East Valley Ophthalmology, Mesa, Arizona, USA. And he's going to be talking to us about anterior vitrectomy and anterior and posterior maintenance.
Oh, good morning, everyone. Early morning from Phoenix, and Merry Christmas to all. And thank you so much for having me. Just a great talk to start the session. That's an excellent anterior flap sign there. So I have the distinct pleasure of talking about everyone's least favorite topic, which is having to do the vitrectomy. But it's very important to master vitrectomy. I don't have any financial disclosure for this topic. And here's some of my most important points. First of all, do not operate from a position of fear. Operate from a position of confidence. Know that you know the right techniques and know that you can handle this problem. This is going to make your mental mindset much more successful when you have vitreous present. So master the vitreous. Do not fear it. So there's a couple of key points here that I want to talk about when you're doing either a pars plana vitrectomy or either an anterior vitrectomy. And that is, number one, do not allow hypotony. This will just cause more and more vitreous to keep coming forward. You have to put an infusion. You have to tamponade on things with viscoelastic as indicated. The first thing you should do when vitreous presents is to manage it. Do not ignore it. Do not be oblivious to it. Do not wish it away. Simply stop what you're doing and get it away from you and away from different fragments or instruments, because the peripheral vitreous is hanging onto the peripheral retina, which is 10 times weaker than the central retina, and it's going to tear if you mess with it without removing it through a safe and effective vitrectomy. Stabilize the lens pieces, as George just discussed. Remove the cataract, supracapsular if needed, and then execute your plan for IOL support. And then finally, there may be iris problems in these cases, and that's what you're going to fix last. So let me start my video here. And you can see in this case, you're looking at a IOL that is dislocated, and you're looking at the edge of the IOL. So it is fallen 90 degrees and it's floating in the vitreous. The very first thing I have to do is do a vitrectomy. So here I'm doing a pars plana vitrectomy. I have infusion set through the pars plana. I'm using my light pipe to illuminate vitreous and a high-speed cutter. And this is a very fast and efficient way. Once all the vitreous is gone, I can reach in with a 25-gauge forceps. And lucky us, this is a 3-piece IOL. So I can simply bring it straight into the sulcus and then do glued IOL. Let's look at the infusion. That's what I'm going to talk about today. Did you see how I came at an angle and then rotated through with the pars plana? Now I have a free hand. I don't have to hold an infusion. So my light pipe is in one hand and extrusion cannula is in the other. After I complete the vitrectomy, the extrusion cannula with a soft silicone tip can be used to occlude the suction on this IOL, and that will be enough force to pick the IOL right off the macula, bring it right up to the sulcus, into the anterior chamber, cut it in half, and then remove it in halves. And I could not do this procedure without that infusion in there to keep the eye inflated. So again, you come at an angle through the pars plana and then push straight in. And then you can remove your trocar, if you don't go all the way in, you'll be in the supraciliary space. And if you infuse here without first checking the position of that cannula, you can have a serious complication. So perhaps you're more comfortable using an anterior chamber maintainer. Certainly acceptable. This is a video from Ashwin, and they're showing how they're removing this dislocated lens. But the problem with an anterior chamber maintainer is it requires a bigger incision through the limbus. And when you pull it out, the chamber can collapse or it can leak. You can see air leaking from around this anterior chamber maintainer. And then you have to put a stitch in there. And so there must have been a better way to do this through the anterior segment. And here you can see a few years ago now, I'm making an incision with my paracentesis blade, just a very small one. And I'm going to take a posterior chamber trocar. But look at how big the blade is and how long the trocar is. I could hit the iris or other structures. That's not that safe. So Dr. Agarwal came up with the trocar AC maintainer. And it's all nicely packaged from Mastel. I have no financial interest. It comes with an infusion cannula, but it's shorter and designed to go at a 45-degree angle from the limbus, and then introduce this specially designed trocar AC maintainer for the anterior chamber. And then you can plug in your infusion line. And this is excellent because now you have infusion anteriorly. And if you do vitrectomy posteriorly, it will pull vitreous strands backward and they disappear like magic. So here's Dr. Agarwal doing this, 45 degrees from the limbus, and then advancing this trocar in. And we're ready for infusion to keep our eye inflated, as you see is doing a glued IOL there. So very, very important to keep infusion in the eye. And I'm just showing you a couple of different ways to do that for glued IOL, for other things. And when you pull it out, it should be self-sealing at the limbus there. And so here's a case of mine where you can see I've already done my scleral flaps and marked the horizontal meridian. And now I'm inserting the AC maintainer, the trocar AC maintainer. And now this case, there's already been a vitrectomy done. So I can just reach down and pick up this one-piece PMMA lens, a large PMMA lens that normally require a large incision to remove. Why do that? Simply inflate the eye and then do the handshake maneuver through a sclerotomy. And you can do a glued IOL with these one-piece PMMA lenses, which last forever. They're fantastic lenses. And this patient had everything done through his dislocated lens, through a paracentesis and 2 sclerotomies. And he was very happy. And the surgery went very quick and smooth. So those are just a few tricks with using the infusion, which is the most important point when you're going to do the vitrectomy, is keep that eye inflated and prevent the hypotony. Now, I like to make all scleral incisions before I enter the eye with flaps and tunnels. I place my vitrectomy ports as the first entry into the eye so that I can get the infusion going right away and keep the eye firm. I manage vitreous as soon as I see it. You can, of course, put triamcinolone to better visualize vitreous. Always inspect your peripheral retina after vitrectomy to make sure you don't have a hole or tear that requires laser or tamponade. And it's always a good idea to leave a little air in the posterior segment to tamponade these sclerotomy wounds. When you're using the vitrector, you can eat iris as fast as vitreous, so avoid the iris and keep the port away from it. Don't tug on vitreous, just leave your probe in one place until all the vitreous in that area has been eaten up and then move to a different place. But don't move the vitrector while it's engaging vitreous. You could tear the peripheral retina. But don't ignore those holes or tears or pretend like they might not exist. Always go looking for them. You don't have to induce a PVD. You shouldn't mess with anything outside your specialty like peeling retinal membranes or anything. Just get the vitreous disentangled. And once again, do not allow hypotony. The infusion is essential.
always put a little suture through their little Prolene suture and fix it that way. You should have stopped him.
No. George.
Hey guys, we are live again.
I think it's working now, yeah?
Yes,
I can see it on another device.
We're live again.
Yeah.
Andrea, really apologize for this, so please go ahead. Namrata?
Okay, great.
Yeah.
Thanks,
So yes, I was talking about the technique I prefer to fix the aphakia. So I always like to associate the posterior pars plana vitrectomy to correct all my aphakia patients. So in this particular case, I opened a wound 5.5 millimeters posteriorly and placed the trocar on the pars plana, as you see here. After completely vitrectomy, I lifted the 3 pieces intraocular lens and I grasped it with a special forceps in order to remove that. And I use a Carvalho to close the pupil. And once that's done, I'm positioning the claw lens in the right positioning, and with special forceps, I grasp the lens and clamp in the posterior to the iris, which I think is the best positioning. You have to remember that the intraocular lens calculation, the corrected power of calculation is different if you put anterior or posterior. So that's something you have to pay attention on it. And once that's clipped on the iris, you just leave it, and the iris usually is like that at the end of the procedure. You may suture, one 10-0 nylon is enough, and I always remove the posterior viscoelastic to avoid glaucoma. I like to use the T-cell glue to reduce the risk of hypotony in those cases. We don't have to do that. And this is a different case. This patient has a multifocal intraocular lens, and I remove it. As you see here, the same technique I did for the first time. Once you get used with this technique, I think that's the best way to correct those problems. As you see here in this particular case, I didn't use the special forceps to hold the lens, which I think I would recommend for every case. In this particular case, I did a different technique. I did after a corneal wound, I did a anterior vitrectomy, and I realized there was a intracapsular ring fixated with 10-0 nylon in the eye. So I have to remove this ring from the anterior chamber, and I did a full vitrectomy. And once that's done, the iris doesn't look good. So I decided to use Gore-Tex to suture the Ayres lens in a pars plana. I think is my second favorite technique to fix those problems. And once that's done, so I decided to do suture the iris just to look better. And I also like to use endoscopy to check the sclerotomy, to check the positioning of the intraocular lens, to check if the suture is well positioned. Sometimes I find bands of vitreous or bands of massive tissue that has to be removed to avoid intraocular lens malpositioning. In the end, I also use the T-cell glue. In this patient, this patient had a retinal detachment. He had operation before. As you see here, the retina was completely detached. So I did a 180 degrees retinotomy, and I removed the anterior capsule there was inside the eye. And with the same technique, I decided to fixate the Ayres lens with a Gore-Tex suture, as you see here. And I think that's very important in this particular case because I placed a silicone oil at the end of the procedure, and it's very important to keep the silicone oil in the posterior chamber. If you don't put the intraocular lens, the silicone oil will migrate to the cornea, and you touch the endothelium and you'll damage. And after the positioning of the intraocular lens, so I decided to close the iris, and with the instruments, I did a laser air fluid exchange and placed the silicone oil inside the eye. there's a last case, and this patient was operated by one of my fellows. This patient had a recurrent vitreous hemorrhage associated with glaucoma and uveitis. So we did a UBM before, and the patient had these 3 pieces intraocular lens that was touching the sulcus and causing the iritis. So with endoscopy, it was possible to check where the intraocular lens was and the sulcus touching the ciliary body. And we think that may be the cause of the recurrent hyphema and the recurrent glaucoma. So as you see here, it's very nice to have an endoscopy associated with the posterior vitrectomy because you can check the positioning of the lenses and the anterior chamber and the capsule. So that will help us to decide for the best of our patients. Once that's done, we remove the lens and remove all the capsule bag, and we check the posteriorly. And also, it's possible to do a kind of gonioscopy. And also very interesting because sometimes if you see a hemorrhage or you see silicone oil on the angle. As you see here, the ciliary body was there was no problems. So remove all the remaining vitreous and all remaining cortex. And after that, we did a high stent implantation because the patient had glaucoma. Everything in one single procedure. And the patient was left actually aphakic because this patient he was highly myopic patient, and the intraocular lens, the calculation was 2.0. So we decided to leave him aphakic. So not every patients we put on intraocular lens, but I like to present this case just because of the endoscopy was very interesting and make us to think about that. So I think you should consider pars plana vitrectomy in all cases that you consider correcting the aphakia. I think you're going to have less problems. Even for anterior segment surgeon, I would consider train the surgeons to be more comfortable in the posterior part of the eye. Thank you for the kind invitation.
Thank you, Dr. Andre Maia, for that wonderful presentation. And now we'll have the next presentation from Dr. Brandon Ayres from Wills Eye Hospital, Philadelphia, Pennsylvania, from USA. And the presentation is on sutures and ring segments.
Welcome to World Aphakia. My topic is sutures and segments. This is my financial disclosure. Nothing will impact the subject matter of today's talk. The course description is basically going to be video-based, showing complex cases. Almost everything you're going to see is going to be off-label, and our goal is to get through 5 techniques in the next 5 minutes. You're going to need some extra materials during these cases, a multiple selection of sutures, as well as intraocular forceps and a vitrector. I want to first talk about trying to save the capsular bag. And whenever you're dealing with the zonulopathy, there's 2 basic rules: stabilize the capsular bag and properly deal with vitreous. In the case you're watching, we're at the end of a traumatic cataract removal. The cataract's already been removed, and we did use a capsular support hook or 2 to get this cataract out. The IOL and a capsular bag is now in, the IOL and a capsular tenturing is now in the capsular bag. We've already performed a pars plana-based anterior vitrectomy. A Ahmed segment, about a third of a capsular tenturing with a suturable eyelet, is now being laced with Gore-Tex suture. The Gore-Tex suture is externalized through sclerotomies, approximately 2 millimeters posterior to the limbus. The CTR is then placed, or the CTS is then placed in the capsular bag, and the suture is used almost like artificial zonules to center the lens. Depending on the level of zonulopathy or degree of zonulopathy, you may need 1, 2, or even 3 of these segments to properly center the lens. Now, what if you don't have a capsular bag at all? There are a variety of ways that we can suture an IOL. One of the simplest techniques is iris fixation. This is a great technique when you want to be minimally invasive. It simply requires a 3-piece IOL, leaving the optic anterior to the iris and capturing the haptics posterior to the iris. Using a 10-0 polypropylene suture I like to use the CIF4 needle. The needle is drawn through the iris, under the haptic, and back out through the iris again. This will capture the iris and the haptic. The knot can be tied using a variety of techniques. In this case, we're using a mechanical suture. Once both sutures are tied and the knot's cut, you can then carefully prolapse, and I do stress prolapse the optic through the iris, putting it back in the posterior chamber. And then simply tugging on the pupil border can allow a little bit more of a rounding, if you will, of the pupil border to stop some of the peaking that we often see in the iris suture technique. Now, what about suture fixation? Well, the key to success with any scleral fixated IOL with suture is measurement, 180 degrees across the visual axis. I like to go about 3 millimeters posterior to the limbus and put my sclerotomies approximately 4 millimeters apart. Any small incision sutured IOL is going to require careful balancing of the suture and then burying the knot into the sclerotomy. Here we are midway through our technique. This is a dislocated IOL in the capsular bag. The IOL capsular bag subring ring is going to be removed and a vitrectomy performed. We're using the Bausch & Lomb AO60 implant, a hydrophilic acrylic IOL. The Gore-Tex suture is laced through the haptics on both sides, creating mattress sutures. The IOL is then placed in the posterior segment, and the suture is carefully balanced, and then the knots buried for placement of the IOL. The technique works beautifully, but opacification of the hydrophilic acrylic material has been described, especially when exposed to air, gas, and silicone oil. So the technique works, but the material is the Achilles heel. So can another implant like the MX60 be used using a similar technique? And the answer is yes. There are some reports of the MX60 breaking. Again, this is off-label, but here we're suturing using the same suture technique, the Bausch & Lomb MX60 toric. So the advantage of this is not only in the hydrophobic acrylic material, but also that we can manage astigmatism using a sutured IOL technique. At the end of the case, we've got beautiful alignment of our IOL in the steep axis. Now, the recent rage has been intrascleral haptic fixation, or the Imani technique, where a 3-piece IOL is placed, the haptics externalized, and then cauterized using low-temperature cautery. Measurement is also key. Straight across the visual axis, 2.5 to 3 millimeters posterior to the limbus, then using an intrascleral channel of about 2 millimeters. This uses a thin wall 30-gauge needle or 27-gauge needle, depending on your technique. A quick tip to make this easier is a net trailing haptic. Make sure you shift that incision a little bit to the left. That'll help you align that trailing haptic in the thin wall 30-gauge needle. Here we are placing the IOL, our 3-piece IOL is already in the anterior chamber using an anterior chamber maintainer. The haptic is carefully grasped and then placed into the lumen of the thin wall 30-gauge needle. This needs to be done for both haptics prior to externalization. Once the haptics are incarcerated, we can then use low temperature cautery to melt the haptic, preventing prolapse back through the back through the scleral wall. So an elegant technique works very nicely, but the Achilles heel is in decentration and tilt with these implants. So let's quickly review. There are multiple techniques available for fixation of an IOL in the absence of capsular support, including trying to save the capsular bag when possible. Suture fixation of a hydrophilic acrylic IOL is effective, but you have to watch out for the material, and that same technique can be modified for either the Imani technique or for Gore-Tex fixation of a hydrophobic acrylic IOL. Thank you for your attention.
Great. That was an excellent talk from Brandon Ayres. Excellent videos. While we're preparing for the next talk, George, I wondered what your thoughts are about suturing one-piece acrylic lenses to the sclera through these eyelets. Is there any concern for UGG syndrome with chafing from those long haptics sticking off of the one-piece lens?
I tend not to suture the one-piece lenses. I'd rather take those out and then put in a 3-piece lens. I think the problem is with tilt and decentration, if you're using that one-point fixation. The other thing is you have to leave those sutures a little bit loose in order to, to stabilize that lens. And so I'm not happy doing that. I'll take the one-piece lenses out. It's easy enough. You just put them in the anterior chamber, cut them, take them out, and put in your favorite 3-piece. And I tend to go to a hydrophobic acrylic 3-piece for the reasons that Brandon said. We're worried about opacification of the optic, and hydrophilic lenses are certainly an issue there. And with silicone lenses, we're worried about silicone oil being used. These are complex cases, and you want to make sure that any eventuality is dealt with. So a hydrophobic 3-piece is my go-to.
Thank you. Our next speaker will be Dr. Durval Carvalho at the CBV Hospital de Lojos in Brasilia, Brazil, speaking about instruments needed for scleral fixation. Please.
Hello, everybody. It's a great honor for me. Okay. It's a great honor for me to be part of this panel and talk to friends around of the world. My lecture about the instruments need for sclerofixation. In the past, we have just needles and the rigid IOL. So here today we have needles with thin wall, 30 gauge, and micro instruments that give us a great evolution of the secondary implant. My favorite microforceps is this micro-holding forceps with have a tooth in the inner surface. You can hold the IOL and Aphakia, whatever you want. This is a maneuver to take the Aphakia in the right position at the sulcus. I call anterior IOL levitation. It's you can check this when pull the suture and the IOL keeping don't move. Another micro-holding force is by Chi, the subluxating IOL grasping. It has a ring at the tip, so you can tight the IOL and the IOL becomes very stable. She used for Ayres fixation and to clean the fibrosis around the IOL. The micrograspers done by Ahmed, it's very nice instruments too. I work on this technique that I call hapticoplasty, and with the Yamani technique and the IOLs decentered, you can twist the Aphakia with the two microforceps, one microforceps and one micrograspers. So it can center the IOL after you do the Yamani technique. There is another variation with Aphakia micrograspers. Here in the Aphakia micrograsper and Dr. Figueiredo manipulator. It's very interesting too, the IOL cutting scissor. The micro cutting scissor is very nice instrument for explant the IOL. I did this zigzag explant technique that I call, and when you divide in three thirds, but not complete, so the IOL explanted like a spaghetti. You don't lose any piece to the posterior pole. And for suture instruments developed by Ahmed is very nice because you can tie and use the needle driver. You can do this intraocular in the anterior chamber. It's very smooth. It's a very interesting instruments. And for capturing suture, I like very much the condom snare too. It's you can capture the suture inside the eye and don't lose. And you can help us to tight the suture at the Aphakia. It's very nice, and I highlight the sheath suture retrieving too. It's worked very well. The injectors. We have a OTA needle injector when you use the AB internal technique, and I have the outsert injector from Alcon. It's automatic injector. You can dismiss your assistants to have one free hand. And one system that we help us a lot to understand the sclerofixation is the endoscopy. This is technique developed and defended by my father, Dr. Carvalho. You can, with endoscopy, you can achieve the right position at the sulcus, the perforation. So it can help us to do the right thing to the sclerofixation. And after you implanted the IOL, you can check it. It's the great advantage of the endoscopy. If the Aphakia it's in the right position, and it is help us a lot to discover some causes of dislocating IOL, and now you can check in the right position at the sulcus. It's a very helpful system. And this is a maneuver that we mix many instruments. I call it three-hand maneuver. It's a case of the one-piece IOL was tight and subluxating IOL. So I use endoscopy, microforceps, and micro scissors in the same eye. So we have to cut the suture from inside the eye. This is what was possible just with the endoscopy. So we have many cases the endoscopy make difference. This is an instrument by Yamane. This is a stabilizer ring Yamane. It's very helpful to achieve the right position, right perforation of the needle, and it will offer you the right angle. And this is was talking about the one-piece fixation, one-piece biofixation. This is a new technique that I'm developing. This is a modified Canabrava and Yamane techniques and used to the Prolene 500 is a piercing. You pierce the IOL Aphakia. This is a Ray 1 trifocal, one piece. So you can transfixate the Aphakia and pass the Prolene 500. So in this case, I did two sutures in the same Aphakia, and you can check the Aphakia by endoscopy. It's not at the sulcus. So this is the final piercing. Thank you, my international guests, for our second edition of fixation secondary implants, and invite you to the Nebraska's to the next year in Salvador. Thank you very much.
So thank you so much, Dr. Durval, for your wonderful presentation, which covered all the instruments possible. So George, last question for you. If somebody was to have basic instruments, which instruments you would say that, one needs to add to your normal cataract surgery set, if you have to do these kind of procedures?
I think the graspers, the micro graspers, are the most important things that you need, and you need two of those. I tend to stay away from the tooth graspers because I find that some of the haptics, if you grab them with that, it'll break off the haptic. So just a straight edge on the micro graspers. They're available from a number of different companies. MST obviously is the big company, but they're also available from Epsilon and Asico and a few others. And a good pair of scissors for cutting that are able to cut the IOL. So I think those are the three instruments that you should have available to you as a start.
Okay, so I think Naveen, Dr. Naveen, can we conclude this session?
Yes, thank you everyone for that excellent series of talks and videos. We'll go ahead and end this session and move on to the next one, which is session 2. So I'll turn it back over to Ashwin, Shin, and Sergio.
Thanks, Naveen.
Thank you. Let's move to the second session. Second session has 7 wonderful lectures. This session includes talks about ACIOL, Ayres Crow IOL, and Suture IOLs. Ashraf, please start session 2.
Hi, Shin. Hi, everyone, and it's a pleasure to be in this great event worldwide. So, can we start with the first topic with Bill?
Okay.
She's going to talk about the aphakic eye intraocular lens implantation.
Yes.
The RIP is Elizabeth.
Okay. I don't. I want to see my video. Or I don't see video. Do you see video?
Not yet.
Not yet. Okay. Thank you. For all, I will present my personal technique that joking that call RIP technique. This is because the name, and we can. In the field of the surgical options to correct aphakia, retropupillar become more frequent, more popular. But why? Because low complexity technique and independence of anterior chamber depth, but require a wide corneal incision, we know it, and because it's behind the iris, it's difficult to ensure the symmetry and enclavation. So to minimize these problems, I developed a technique. But as usual, in the retropupillar, you need to implant upside down the IOL and change the oofs. Okay, good. And change the constant. There's what I use to help the implantation, the enclavation, because the problems that I said, I use a needle, the terminal-prolid long straight needle that I insert through limbus from one side to another, and then I perform the enclavation. In this case, I perform in 2 steps, but you can put the length, all the lengths behind the iris if you need it. And then you look at the stroma and in the needle also. And the other side, you can perform the same. For me, the advantage to use the needle is to ensure the symmetry of the enclavation. Because it's anterior segment surgeons, it's difficult to ensure this enclavation. You can lock sometimes, you can lock different times, 1 time, 2 time, and check all the enclavation, and then in the end remove carefully the needle. I always perform a complete anterior vitrectomy, and because precaution, I perform superior iridectomy, and the visual results and functional results is very good. It's not possible to talk. This is a case of aphakia, traumatic aphakia with coloboma, traumatic coloboma that I use the same procedure, and this is a case that requires pupilloplasty, but you can use in this case the same way to lock the iris, the stroma of the iris, and the needle help us to ensure the centration and also some safety. You can see that after suture, no problem. The resistance of the enclavations is enough to ensure the stability of the IOL, the iris claw IOL, even after suture, that you can see. I always use also Malone disc in the end and some in white incisions. It's a very good to ensure and to control some astigmatism, and the result, as you can see, is very good. The pupil very regular. And this last case is a case of exchange of complex, the IOL bag complex, that I use the same procedure, corneal incision in this case. I use more times, sometimes scleral tunnel to avoid the stigmatism. Posterior stigmatism is much faster, and that to illustrate to the technique, can use a spatula to ensure the inclination, and it seems that it's a little bit the stroma, but no problem. It's enough, and also allowed us to control always the place of the IOL, and you can perform. For me, it's paramount. So I have very good results with this technique, and I can say that few complications, very good aspect, and you can see that I have a follow-up of more than 4 years, and without complications. So I think the smaller devices are a great help to these techniques. Thank you for your attention.
Thank you, Isabel. Priya.
So that was a great talk, I think, by Isabel. And we move on to our next speaker. The next presentation is from Nicole Fram. She'll be covering up the Ayres sutured IOLs. Can we have her presentation, please? Can we have the presentation of Nicole Fram?
Thank you so much for inviting me to speak today on IOL exchange and iris suture fixation pearls. My name is Nicole Fram, and I'd love to share this video with you. Now, this is a patient that had beautiful cataract surgery, has an Acrosoft toric IOL in the bag. The patient has positive and negative dysphotopsia and requires an IOL exchange. Here I'm using the Donenfeld femtosecond spatula for a different purpose. It fits perfectly under the anterior capsule, and then I'm using a dispersive viscoelastic to viscodissect. In addition, as the late Alan Crandall has taught us, you want to go down the optic-haptic junction to try and loosen up the haptic. Now you can see here that we put a lot of viscoelastic in, so we want to burp the viscoelastic out, and instead of ruining the zonule, we're actually going to amputate these haptics, because often when we amputate the haptics, we can then get the optic out, and then the haptics will come out of the bag more easily. So we're using 23 gauge MST scissors and 23 gauge serrated forceps to hold on to the lens, and we're amputating these haptics. Next, we use the 23 gauge serrated forceps, and we go ahead and cut with 19 gauge scissors. And here we can bisect the optic very easily using these micro instruments. Now you want to pull towards you as you're cutting so that you can make sure you're not engaging the anterior capsule. And then we always block when we pull this out of our 2.4 millimeter incision, which we will enlarge to 3 millimeters to accommodate the 3-piece IOL we're going to put in. So you could have left these haptics in, but you can try to viscodissect down the cocoon that is created around these haptics. Now, with the Acrosoft platform, what you see is that you have fibrosis around the terminal bulb. With other platforms, it's at the optic-haptic junction. But if you follow the curvature circumferentially, you can get these out. Now here, we were in the wrong position sitting temporally, so we moved. And really, when I'm just pulling, I'm just going to affect the zonule. So I keep viscodissecting, and the key is to have counter traction. So I'm using the spatula and the 23 gauge forceps, and I'm creating this counter traction so that I'm not pulling on the zonule, and you'll see that that terminal bulb came right out of the cocoon safely, and then we'll take this out. But once again, we could have left these haptics in the bag. Now, for the negative dysphotopsia, we need to move the optic forward and cover the nasal capsule. That will shift the shadow outside of the patient's view. For the positive dysphotopsia, we want to change the IOL material. Now, because this rhexis is so big, we can't do an optic capture, so we need to fixate this 3-piece lens that's in the sulcus. And what we're going to do is use iris suture fixation, and this is a mechanical technique. This is a CTC6 needle. It's on 10-0 polypropylene. And sometimes it can be tricky to get in through a paracentesis. So we can use a second instrument as a guide. Now, the reason why we get an ovalized pupil is because our bites are too big and they're not peripheral enough. We'd like to see that the pupil came down a little bit more when we put in our intracameral miotics, but this will do. The optic is on top of the capsule so that you can see the haptic underneath. Now here what we're doing is we're using bond hooks, but you can use a Kugeln hook and you can use a Condon snare. And we're going in and we're retrieving the suture-free ends. And we retrieve them to make these loops. They kind of look like bunny ears. Then we figure out which end is free and we retrieve that so that make sure you're not pulling on the end that's connected to the iris. If you pull on the end connected to the iris, you'll be very sad because you have to start over. Next, we do this on the other side. Now you'll notice we have a bit of heme. Why do we have the heme? Because the paracenteses that I made were too peripheral. And so we want to try to avoid that in the future. And you need to get rid of these clots because you can't see what you're doing. And sometimes when you start tying, the clot will then go on the knot and then you don't get a complete knot. So here we're going to tie in a 2-1-1 fashion, and we'll go ahead and just tie this gently because remember we have the whole sulcus supporting the lens. These sutures are just there to make sure that it doesn't move over time. Now here we see that heme. We're going to try and get rid of that before we secure down that knot. And we just continue to tie one side and then the other, and then we can go ahead and cut these knots right at the limbus to allow for nice titration of the suture end. So here we'll just cut that right at the limbus. Next, we want to make sure that we sweep where these knots are so that they're not incorporated in the paracentesis. And then when we reposit the IOL posteriorly, you just push down. You don't want to rotate the haptic out of the knot and then not have a secure fixation. So here we see we have a relatively round pupil. We're sweeping again to make sure everything's okay. And then we're going to remove the viscoelastic using bimanual irrigation and aspiration, intracameral moxifloxacin, and then checking that the eye is normotensive and that there's side L negative. And so the patient finished up nicely, did really well. The positive and negative dysphotopsia were resolved. And this is a very clear, good explanation of why iris suture fixation fits into our armamentarium. Thank you so much for your time.
It was a very great, elegant way in handling the case, really. So our next presentation will be by Richard Hoffman, talking about the Hoffman pocket, which is one of the best, and I like this technique so much. And we are going to hear it from Richard Hoffman. So please, can we run the presentation of Richard?
Greetings, participants of this World Aphakia course. I'm Richard Hoffman. I'm going to talk about secondary IOL implantation using a corneal scleral pocket. The original description of this technique was in these patients who had sublux capsular bag IOL complexes, but the reality is this technique can be used in any instance where you want to fixate any device or an IOL to the sclera. It's especially useful for secondary IOLs. The first step is to make two corneal scleral pockets that are 180 degrees apart from each other, and then a double-arm suture is passed through the full thickness of the globe corresponding where these pockets are. The needles are removed, and then the suture ends are externalized by placing a Sinskey hook into the pocket and pulling each end out. These suture ends are then tightened and tied, allowing the knot to slide under the protective roof of the scleral pocket. And what I'm going to do now is just describe the technique of fixating a foldable three-piece lens using a cow hitch knot for fixation. So in this particular patient, two corneal scleral pockets have already been created to the right and to the left, and then this suture is passed through the full thickness of the globe by docking it into a 27 gauge needle. And what we do is we leave a loop of propylene suture outside of the eye and then fold it over onto itself to create this cow hitch knot, which is attached to the leading haptic and eventually the trailing haptic of the IOL. What I'm going to show you now is a video of a transplant patient who had some trauma, extruded their IOL, and then needed a secondary IOL. So a corneal scleral pocket has already been created to the left, and you'll see one being created to the right. A temporal clear corneal incision about 3.2 to 3.5 millimeters in size is then made, and then this 27 gauge needle is passed through the full thickness of the globe corresponding to the pocket. A 9-0 double arm Prolene suture needle is docked into this and pulled out, and then the second arm of the 9-0 Prolene suture is docked into a second 27 gauge needle, 2 millimeters posterior to the limbus, about a millimeter adjacent to the first pass. And again, rather than pulling that suture into the eye, the loop of Prolene is left outside of the eye, folded over onto itself with the aid of a little dollop of viscoelastic. The IOL is treated on the end to create a little nub with low cautery, placed in a cartridge injector with the leading haptic extruded slightly, and then the cowhitch knot is attached to that leading haptic. The haptic is placed in the eye, the cartridge injector is placed in the eye, and then the IOL is injected into the anterior chamber, leaving the trailing haptic outside of the eye. And tension is kept on those Prolene sutures to keep the knot tied tight. And then once the IOL is in the eye, the same thing is done for the trailing haptic on the other side with this left corneal scleral pocket. And once that suture is attached, the trailing haptic is brought into the eye. The needles are removed from the sutures, and then the ends are retrieved with a Sinskey hook placed into the pocket, externalizing each of the suture ends. These are then tied with a 3-1-1 surgeon knot. The knot is trimmed at the knot, and this allows the knot to slide under the protective roof of the scleral pocket. And the same thing is done on the other side. There are several things to keep in mind when you're performing this technique, and most importantly, you want to start with the right hand pocket. So if this was a patient's right eye, the right hand pocket is located inferiorly. If this was the patient's left eye, that right hand pocket would be located superiorly. And the reason that you start with the right hand pocket is that if you started with the left hand pocket and then you pulled on that Prolene suture, you could pull the knot off of the tip of the haptic. But by starting with the right hand pocket, when you put tension on that suture, the worst thing that's going to happen is that knot is going to slide to the haptic optic junction, and it won't come off of the IOL, and you can always readjust that suture inside the eye. So always start with the right hand pocket. You can use 9-0 Prolene or CV8 Gore-Tex, and by using a scleral pocket, it has some advantages. It eliminates the need for conjunctival dissection, which is useful in patients who have pre-existing glaucoma blebs. It's also useful in patients with a lot of conjunctival scarring, such as individuals who have scleral buckles or post-pars plana vitrectomy. It covers the knot without the need for a rotation of the knot. It allows for simple 4-point fixation, which should result in less lens tilt, and ultimately it's more comfortable for the patients because there's no sutures in the conjunctiva. Thank you for your attention. Everyone have a wonderful day.
Thank you, Richard, so much. Priya, it was a great presentation, really.
Yeah, it was a great presentation, and we had a lot of teaching tips from Dr. Hoffman's talk. So we move on to our next speaker, and then maybe we can have some discussion around. So we move on to Dr. Chi, and we know that she's a great surgeon. So we look forward to her talk. And Dr. Chi will be talking about suture fixated IOLs.
Hello everyone, I'd like to thank Ashwin for inviting me to speak on scleral suture of IOLs. These are my financial disclosures with no relevance to my talk today. Here is an eye that is aphakic as well as inuridic, and we are creating a scleral groove 2 mm posterior limbus diametrically opposite. We then create a partial thickness 10 mm incision superiorly. We thread a 26 gauge needle with cortex suture to create a suture snare. We clear all the vitreous, and then we introduce the suture snare 1.75 mm posterior limbus. We extend a loop of the suture to lasso the end of a cortex suture bearing a needle. We do that for the opposite side, and then We retrieve this to 1.75 mm posterior to the limbus. We now thread the needle through the eyelet of the Mocha LL and railroad the needle through a 27 gauge needle, 1.75 mm posterior to the limbus at the fixation point. We repeat this for the other haptic eyelet, railroad the needle into a 27 gauge needle. We enlarge the incision now to 10 mm and introduce the LL into the anterior chamber, which is being maintained by an anterior chamber maintainer. We then tighten the sutures and ensure that the LL is well centered. We close up the incision superiorly with 10-0 nylon so that it is watertight at this stage, and then we center the LL by adjusting the tension of the 211 knot. It's very important at this point in time to ensure that the knot is completely buried in the incision into the anterior chamber. You can see this diagrammatically on the left. You can use this technique for various types of IOLs, as you can see here. Now this eye, we're going to show you how to do a 4-point scleral fixation with a 3-piece IOL, so 27 gauge needle, docking the cortex suture at 1.75 mm posterior limbus through the Hoffman pocket, which are placed diametrically opposite. We then retrieve the 2 sutures out of the incision temporally. We then tie one cut end of the suture to the haptic using the round, turn, and 2 half-hitch knots. We repeat that for the other suture, and then we flange the haptic at the end so that this will not slip out. I'm going to show you now this knot on the left. The LL leading haptic is inserted to the anterior chamber, which is being maintained by anterior chamber maintainer. We then do the same for the trailing haptic, so we have 2 suture point fixation per haptic using the round, turn, and 2 half-hitch knots, as you can see here on the left, diagrammatically shown now. And then we flange the end of the haptic to ensure it doesn't slip out and introduce this into the anterior chamber as we tighten up the sutures. And by adjusting the tension of the sutures, we then center this IOL. We then retrieve the sutures from the Hoffman pocket, and then we tie a 211 knot and allow the knot to slip back into this corneoscleral pocket. And at the end, we achieve a very well-centered, stable IOL with a 4-point fixation. So we're going to do a similar technique, but this time we are going to inject this IOL, and we have already pushed out the leading haptic, which we tie with 2 cut sutures, flange the tip, inject it into the anterior chamber, leave the haptic trailing outside, and then we tie on 2 more sutures, flange it, and then introduce this into the anterior chamber, tighten up the sutures to center the IOL. We then retrieve the sutures from the Hoffman pocket and finalize the lens. So in summary, we can fixate IOLs with eyelets on haptics, or 3-piece IOLs with Cortex 7-0 suture, avoid IOLs with an interior square edge, which will cause iris chaffing. Thank you very much for your attention.
It's very great technique, she. Excellent, really. A lot of teaching points, really. Our next speaker is Ayres. He's one of the great inventors in ophthalmology, and he's going to talk about the suture fixation IOL with a 6-0 double flange approach. Can we start the video of Ayres, please?
Hi, I'm Ehud Asian. I would like to present to you suture fixation of intraocular lenses with 6-O-Prolin using adjustable flange technique.
Can we start the video again, please?
While they prepare the video, I like to say 1 year ago, I thought I was the master in double flange, but now Dr. Ehud's know more than me, okay? Dr. Ehud is the master.
Hi, I'm Ehud. Hi, I'm Ehud Asian. I would like to present to you suture fixation of intraocular lenses with 6-O-Prolin using adjustable flange technique. These are more disclosure, none is relevant to this presentation. Surgical Bravo from Brazil presented a technique for fixation of intraocular lenses using 5-O-Prolin and designated punch. We have further modified this technique using 6-O-Prolin, and this suture has a very nice needle that can penetrate quite easily through the hydrophobic lens material. We create punch flanges on both sides, and then the suture is externalized using a 27 or 30 gauge needle. The IOL is implanted using folding forceps or designated cartridge and an injector. And once the IOL is inside the eye, the sutures are cut on the external part and flanges are created to fixate them to the scleral wall. Here is a clinical case of a patient after ICCE. We first prepare the lens and note that the flanges are positioned at the back of the IOL away from the iris to prevent chafing. The lens is then inserted into the eye only after the sutures are externalized. So this makes it very safe technique because the lens cannot drop posteriorly into the vitreous cavity. Now we cut short the suture and create the flanges using high temperature single-use cautery. And then we adjust the suture to create a proper tension and ensure that the lens is well stable and centralized. This is the patient and what day post-operatively. The same patient at 1 week, we can see the internal flange on the left and the external one on the right covered with conjunctiva. Here is another case of a patient with a dropped nucleus after removal of the lens through a large incision. We externalize the suture and then implant the lens through this small pupil. And this is one major advantage of this technique because we do not need to do any intraocular manipulation unlike other techniques. So this makes this technique very safe even in small pupils. Now we externalize the suture, cut, and create flanges and stabilize the IOL. What about the hydrophilic lens? And here we studied it in the laboratory, and we inserted the needle at various locations along the optic, and even at the very tip of this thin haptic, and also at the optic. As we can see, These sutures are well fixated anywhere along the optic, and using a considerable force, it does not come out. Here is a clinical case in which the IOL is inserted after the suture has been externalized. By pulling on both sides, we make sure that the IOL is well centered, and then we cut the suture and create the external flanges and adjust to make sure that the lens is properly positioned. Alternatively, one can use closed loop, and this is a case of a patient with a Marfan syndrome. We enlarge a small pupil with the APX, make the vitrectomy, and then implant an IOL. And in this case, after externalizing one suture, we pass the other side through both closed loops on each side. So eventually we have a 4-point fixation, and this may create a very stable lens with no tilt and no need to penetrate through the lens material. The IOL is folded, and I prefer to use folding forceps, and pulling the suture on both sides ensure a well-positioned and well-stable intraocular lens. One can use also PMMA lenses, such as this one, aniridic lens with a brown color. This patient, luckily, he had the colors of the eye with matching to the color of the IOL. So to summarize, adjustable flange technique using a 6-0 Prolin can be used in aphakic eyes in a variety of scleral fixation techniques, either by passing the suture through the lens material of hydrophilic or hydrophobic materials, use either 1-piece or 3-piece design, passing the suture through the optic or through the optic. One can use closed loop or open loops or even PMMA. So this technique seems to be a very promising for IOL fixation in eyes with aphakia. And thank you very much for your very kind attention.
Thank you so much, Yud. It's really impressive. And I think we are going to have some questions in the end for each speaker. We are going to just to finish, but really we are going to have a question for everyone. So our next speaker will going to be Manuel Nicole. He's going to talk about the Lewis-Malborn technique. Please, Manuel.
Hi everyone. Good morning, everyone. I want to thank the invitation to Ashwin, to Shin, and especially Sergio. Thank you very much for this, for being here, for the invitation, for being here. It's a very excellent course among these great colleagues. So I'm going to talk about the Malborn's technique. I believe that he began this technique in 1985. He published his work in 1986 at the International Ophthalmology. I recommend everyone to read that. I believe that he's the father of the scleral sutures IOL. I have the chance to do my residency with him, and I talked to him last night. I'm going to show you some cases on how he managed his technique. You can use a foldable or rigid IOL. You put the sutures, the 10-0 polypropylene technique. Then he moved to a 9-0 polypropylene to do his technique. And here we see that he's doing the marcation in the sclera, and he's going inside the sclera, inside the eye. Previously, you have to be sure that no vitreous is there, so anterior vitrectomy is mandatory. And he pulls the first suture with this forceps. It's a Sinski type of forceps. And then you pull the suture outside through the sclerodermis. And one thing he usually does is he puts another suture, a silk suture, through the proline, and he sutured the proline to the silk to both ends of the silk. So he can have the IOL suture quite firm and be very positive about the centration and the outcomes of this surgery. So here we see he's doing the silk with the proline suture. Here's another case where diathermy is done in the scleral bed. Then he performs this sclerotomy. He first measured 2 or 2.5 millimeters from the surgical limbus to do this, to put the sclerotomies. Then he's using another type of lens. It's a PMMA lens with eyelets, so you can put the sutures in those eyelets, and he puts insert the lens, and he managed to retrieve the sutures from the eyelets outside the eye and make the suture as we saw prior the first surgery. These were cases of penetrating keratoplasties, and he's putting the silk, the suture, and suturing between the proline and the silk to have the lens very, very firm. So here we see the end of this case. Here we have another case. Here's the same, but he uses this crescent to make some room in the sclera so we can hide the knot in the sclera. And here we can say that it's a complex case with a penetrating keratoplastic needed. So we are passing through the needle from one sclerotomy, and we are using the other sclerotomy to do the same. Here we don't have any problems to injure the cornea because we're going to replace it. We put the suture on the 3P lens, and we are going to insert the lens over the incision, and then you can see how the suture is pulled out, and then you have the lens in position. Then the case goes with the penetrating keratoplasty, and finally you do the sutures just to center and to adjust the lens in the correct place. The modification that we are talking about now is that Lewis' modification was to use a needle to use as a guide for the sutures, and then you can use in a proper way these sutures. And also, Dr. Malbrand incorporated in 1987, 1988 the sclerals for flaps to hide the knots. So to make sure that no exposures of the knots can occur, and maybe endostomatitis risk be very lower. So thank you for your attention, and thanks again for the invitation.
So that was a great talk. I think we'll have a discussion in the end. Meanwhile, we move on to our next speaker, Dr. David Chang. And David Chang, we all know, we all look forward to listening to him, and he's a legend in himself. So Dr. David Chang, we are all ears to your talk on ACIOL implantation.
Yes, well, thank you very much. Of course, anterior chamber IOLs get no respect, but I'm happy to talk about them because in a lot of surveys, it shows this still is one of the most common ways of IOL fixation without a capsular bag. In our textbook, we highlighted all of these different methods for non-capsular fixation, but I'll point out the only one that's FDA approved is the anterior chamber IOL. Now, here's one that I have to remove. And you'll see that the lens has actually been placed upside down. There is fibrosis, and this is only after 4 months, but there's fibrosis in the angle. In fact, I have to amputate the distal haptic. And the point is that, of course, if you don't implant or don't use any of these techniques properly, there will be complications, and that goes for every single technique that has been described, and anterior chamber lenses, of course, are no exception. And I think what is, this is a good surgeon that's placed this upside down, but it just shows that in the heat of battle, we can do things that don't work out, but that doesn't mean the technique is always wrong. Sizing is important. So here are 3 sizes for the Alcon Kelman Multiflex. And for the typical eye, the middle size works well, but even you can remove one after you've placed it if you think it's too large or too small. So let's look at some situations. Here's a bag IOL pseudophacodenesis, but it's a PMMA IOL with a large optic. So I already have a large incision. I've done a vitrectomy. And then this is the technique. The sheets glide goes to the opposite angle. There's viscoelastic above the sheets glide. You make sure that the lens is not upside down. It is basically vaulted away from the iris. Now I hold it against the temporal nasal angle. I pull out the glide, and then you're dropping the haptic just inside the incision. And then I'll use usually some type of, this is a luster hook to sort of flex the haptic to make sure you're not tucking the iris in the angle. And sometimes you can walk it, in this case, clockwise, just to be sure that we're completely free. There should be no unusual peaking of the pupil. And if it's too tight, you can simply remove it. There's a running suture, a final cleanup with the vitrectomy, and this case becomes very fast and it's very secure, and we have a good IOL power prediction because the effective lens position is always known. There's another case where the nucleus was descending through posterior capsule rupture in a Flomax case, so I'm using a PAL technique to extract the nucleus. Now I've got a huge incision. We do our vitrectomy. You'll see there's a temporary closure. We put in Maia call and then take out one suture, insert the sheets glide. So the same technique. This keeps you from entrapping the iris on the way in. We hold it against the opposite angle. We make sure we're free. And then this flexes it. You make sure the haptic is not coming out of the incision. And then you can make the iridotomy either with a vitrector or here with the large incision. Just do it the old-fashioned way. And we close the sclerotomy, and there is the case. So the earliest OTA from the Academy was just updated literally in the last 2 months. And this is a study that looked at the entire literature. They only found 45 articles that were at least level 3, which is basically a small case report. But they concluded again that based on acuity and safety, no single superior method, a CME and retinal attachment, and glaucoma were actually higher with sutured PC IOLs, chronic uveitis, a little bit more with AC IOLs. So I think we can say there's some relative indications, aphakia with an intact hyaloid, as we used to see with primary intracaps, a large incision where you've already done a vitrectomy. Contraindications might be glaucoma, any type of iridocorneal adhesions, a high risk of needing a DSEC, DMEC later on, and iris defects. But for many people, this is what they are comfortable with, and you just have to make sure you use the correct technique. Thank you.
That was a great talk, Dr. David. For the benefit of the audience, we all know that the sizing of the anterior chamber IOL is very important. So could you like to give just one tip to the audience? How would they decide the right kind of size for that patient, particular patient?
So it should be the white to white plus 1 to 1.5 millimeters. So in our case in the US, the MT4 pretty much meets 80% of the eyes, but you need to have all three sizes there. So basically the MT4 is going to typically be the best size. That overall length of that lens is 13 millimeters.
Nice. So a question to Isabel about the retropupillary very size. Thanks for the needle orientation. This is very nice, but sometimes when you put this phakic IOL, you see the haptic little bit kinked. So how you deal with this, and what's your tips when you put, how you take a good iris tissue in the fixation?
Well, I have a follow-up with a lot of cases. So this needle, I don't see any damage in the haptics, in the claw, okay? Because it's very flexible. Some colleagues try with another type of needle, and this is important because it provoke damage of the claw. And at first, I also have some afraid because it's enough or not, it is enough. And I try, and I see that the claw locked the needed, the iris needed. So I think it's not problem. I have no luxation or the dislocation of the IOL. So I think it's enough, not need no large, and it's because we have the needle is like a guide. If the claw locked the needle, it's enough.
Thank you.
I just want to ask you, suppose if you do not have a good amount of iris tissue out there, what would be your next choice of secondary IOL fixation?
I don't understand the question, sorry. It's for me?
Yeah, it's for you. Yeah, I just wanted to know what would be your second preference of secondary IOL fixation. Suppose if you do not have adequate amount of iris tissue out there to put up the lens, what would you choose next?
Well, depend of type of lens. I use very much suture to the iris because it's very interesting. If I have iris, I suture the IOL, and then if not, I try to suture because I use often pockets because I suture a lot of the rings, and then I suture if a single piece, it's not allowed to, it's not a very good idea. So I try to, I suture with the scleropox and with 9-Perlin, no problem.
My question to Ehud, how you choose the best site in the IOL to go through, and did you find any IOL opacification in the long term or no?
First of all, I will start with opacification. That is not a problem with these lenses. Once, because use usually hydrophobic lenses and they do not opacify. Glistening, yes, opacification, not really. My preference is that I prefer to suture lenses, and I either go with a needle through the lens optic or use 4 closed loop lenses, and I found this the most easiest to use. As for the power calculation, I do not do any modification. I use the same as in the bag because the location is approximately the same. And I don't see any significant deviation. It is not as accurate, but no significant deviation from my calculation.
Can I ask a question, Ehud?
Yeah.
Have you ever tried to remove the haptics just so that the haptics aren't causing a problem down the road?
Yes, to cut the optics. I did in a couple of cases. They do not interfere. They have no value as for the fixation, but they do not interfere. But in a couple of cases, they just cut the optics because they are not part of the fixation. Then they just You're correct. It may rub the ciliary bodies, which we do not like to, but we can cut them off.
Dr. Chi, I would like to ask you that you implanted the aniridia type of IOL you showed in one of the videos. Have you ever noticed any pigment dispersion in these IOLs over a period of time?
Not really. I think as long as there's no tilt in the LL, although it's through a single eyelid. In fact, that patient that I was doing it in happened to be a patient with both Koyanagi-Haradas disease. And you would imagine an eye with uveitis would have more inflammation with the slightest chafing. But no, I don't see it generally.
Can I ask Hoffman, how do you know the exact size of the thickness during doing the Hoffman pocket?
All right, so I start out the pocket with a diamond step knife that's set at 350 microns, and then I will lift up on that posterior lip and go in with a metal crescent blade, like an Alcon crescent blade. And it's helpful if you can see the blade through the conjunctiva and the sclera. You can go too deep and you can be too superficial, but you basically would like to see, just barely see the blade as you're making the dissection. You want to angle the dissection. You don't want to angle down. You want to angle in the plane of the sclera. Does that answer the question?
Yeah. This is great.
Can I just make a comment on the Hoffman pocket, which I use a lot of?
So I think...
could I just make a comment? Yes. Yeah, I think you can use the IOCT, intraoperative OCT, and that can also be a useful guide.
Okay, but no.
Yeah, I think, yes, that is.
You hear me now?
It's a good idea.
Yes, I think it was a very great session, and we enjoyed a lot the different topics in covering everything in the course. Thank you for everyone, and thank you for Ashwin, Sergio, Shane, and everyone is here. Thank you so much.
Thank you everyone for being here.
Thank you. Yeah, thank you.
Thanks everyone.
Thank you.
Priya, I love your new hair, okay?
Thank you.
I told her this. That is.
Let's move on for the last session. My friend Tom, my friend Gerardo will take the words to start this session 3. And Carlo, I'm waiting your IOL here in Brazil for test, okay?
Okay, thank you, Sergio.
Have the intro, please.
Well, hello, everyone. My name is Tom Oning, and I want to welcome everyone here with Gerardo. We're going to do the moderation of this next session. First off, you just can't go on without saying thank you to Ash and Sergio and Shin for setting this up. I mean, it's amazing, and there's another great example of taking advantage of the bad situation of COVID and bringing us all tighter and tighter together. And I just can't thank you all for the effort to set this up. So we have a great session to finish it off, session 3. And we're going to start off with a video from Gabor Shirov. Now, Gabor, I believe, is halfway in the middle of a case, and so I'm not 100% sure if he's going to be able to comment too much. But we've got a video. And he got interscleral haptic fixation all started in 2007 with a very innovative approach. So let's start off with Dr. Shirov's video, please.
Gabor, can you mute yourself?
Wait, what happens there? Yes, this is my presentation. I'm Gabor Shariot, and I would like to talk about our 15 years of experience with intrascleral haptic fixation technique in eyes with insufficient or no capsular support. In this video, I like to illustrate you the basic steps of this technique. Conjunctiva has been opened superior and inferiorly. A pars plana infusion can be used, or like in this case, an anterior chamber maintainer. And then a 23-gauge cannula is used to create a ciliary sulcal sclerotomy. The second ciliary sulcal sclerotomy should be exactly 180 degrees to the first one. From inside the sclerotomy, a new fresh cannula and limbus parallel intrascleral tunnel of about 2 millimeters in length is created. The same on the opposite side, again with a new fresh cannula. Now a 3-piece IOL, in this case an AR40 sensor, is implanted through a corneal tunnel of about 2.6 to 2.8 millimeters. The trailing haptic is trapped in the corneal incision. Now I'm using two special designed forceps, one is straight, one is curved, and with the so-called handshake technique I'm presenting the haptic intraocularly, go with the straight forceps to the sclerotomy and grasp the very tip of the haptic and externalize it temporarily. The same procedure is done on the other side. Again, both haptics are used. The haptic is implanted intraocular. Second haptic in the handshake technique is used to grasp the haptic intraocular, presented to the straight forceps which is coming through the sclerotomy, grasp the very tip. This prevents breaking or damaging the haptic while you externalize it to the sclerotomy. This moment you have a very stable situation. The IOL cannot fall down. I grasp again now with the curved forceps the very tip of the haptic, push it a bit back in the sclerotomy and then introduce it into the intrascleral tunnel. When I went through the tunnel, I opened the jaws of the forceps, release the haptic and pull the forceps back. And then the same is done on the opposite side. It is very important that all parts of the haptic are fully intrascleral. This prevents late erosion and complications of this technique. Another beauty of this technique is that at the end of the surgery, you still have the opportunity for what I call fine-tuning of the IOL. Another advantage of this technique is that it is completely independent from the iris. So like in this case, 30 years after severe trauma with aniridia and aphakia, you can use this technique to safely implant an IOL. And we found that an IOL is much more stable in intrascleral haptic fixation than in transsclerally suture fixated IOLs, and that there is much less risk for an IOL tilt. Like in this case, you can even implant an artificial iris to improve the outcome. What are the recommendations for intrascleral haptic fixation? Symmetrical ciliary sulcal sclerotomies, 1.5 to 2 millimeters post-limbal, exactly 180 degrees from each other. A limbus parallel intrascleral tunnel preferred either with a 23-gauge or 24-gauge cannula or a 23-gauge MVR blade. A vitrectomy should be performed. Capsulectomy should be performed. A continuous infusion to stabilize the eye, either as an AC maintainer or a pars plana infusion. Complete intrascleral haptic fixation. Please use proper instrumentations like the forceps we have designed. In case of leakage at the end of the surgery, please suture all sclerotomies. With about 15 years of experience in intrascleral haptic fixation, we found no contraindication except excessive scleromalacia. It's a standardized technique and uses standard PC IOLs. That means no extra storage and easy logistics. For the biometry and IOL calculation, we use the SRKT formula and calculate for intracapsular positioning of the IOL. We found an excellent centration, like on the right you see a multifocal IOL several years post-operative, well centered without any tilt. It's a sutureless technique and sclerofixation, and the sclera is the strongest tissue in the eye. It shows minimal uveal contact and reduces the risk for UGH syndrome. It is completely independent from iris changes and can be even applied in aniridic eyes. You can use special IOLs like multifocal or toric IOLs. On the right bottom you see one eye 10 years post-operative. And here is the IOL haptic visible shining through the sclera and the conjunctiva without any sign of leakage or inflammation. Thank you very much for your attention, and
Okay, great technique. We continue, and then at the end we make all the questions. Okay. Now with our friend Ashwin Agarwal, you talk about IOL glue.
Well, thank you so much, Gerardo. And must I say, this all started with Gabor back in the day. And we've just basically adapted from there, and it's gone on a long way. My topic today is, in this course, is the glued intraocular lens. And I think it's but I have no financial interest in anything else but ELISA, which has nothing to do with the talk today. The specific instruments that I would say that, if you are starting off to do this procedure, and it's important to know, is you must have a basic vitrectomy setup, you must have a glued intraocular lens marker, a glued IOL forceps, 2 of them in number to be precise, and trocar AC maintainer if you have, a 3-piece intraocular lens, and some fibrin glue, apart from obviously the other cataract stuff that you already have or you need in your practice. Let's start with a complication that happens. You probably have a zonular dialysis like this. And what exactly do you do? You basically suture the wound and you put in a trocar, anterior or posterior maintainer. After you do that, you really are using this flap marker. And I'm talking more about the stuff that really belongs to glued intraocular lens than anything else. Making the scleral flaps is very important, 2 by 2 millimeters in size. Once you've done this, you basically are making sclerotomies. After the infusion is making it taut, then you make the sclerotomies under the flaps, approximately 0.75 to a millimeter behind the limbus. And that does make a big difference. So yeah, that's why the range is important. Once you do this, you actually go ahead and make a paracentesis. You already have your main port wound, which is why I caused this complication of a zonular dialysis while I was doing my phaco. And once you do that, you basically are removing your any cortical matter that's left along with the bag remnants and vitreous. So basically, it's a combination of 3 things that are being removed with a vitrectomy cutter. And that's what we're doing with this in this step.
Live surgery and technique presentation.
Once you've done this, you basically now have to externalize the haptics using a handshake technique. And just in interest of time, I'm going to just show, or in the interest of the step, I'm going to show this one video again. You're basically going in and externalizing one. Then you're using a handshake technique of basically using both hands so that you can bring out both the haptics through the sclerotomies. Once they're out of the sclerotomies, you basically are making the Gabor-Chariot's tunnel, which is very, very important and probably the key to the whole success of all the procedures that we see. You really have to tuck them somewhere, and the sclera is probably the best place to tuck intraocular lens. Some small tricks which can be used: don't hold it vertical or don't hold it parallel, hold it perpendicular, and you'll be able to insert that into the groove that you've made already. And you can go as far as you want. The best part about this whole thing is you can tighter this. The next point that I would want to add is you want to put in some pilocarpine. If pilocarpine sometimes doesn't work, you sometimes get a little bit of optic capture or iris capture like this. And when you get this, please go ahead and do a pupilloplasty of your choice. My choice is the single pass 4th row. It's easiest, it's fastest, and there's no way that you can get faster than this. So a pupilloplasty just avoids any kind of iris capture that you might have. You then close up by removing the trocar if you've put in a posterior or anterior, glue up that flap, and that really tucks it into place. Post 3 weeks, you'll also have fibrosis around that. It's easy, it's pretty simple, and also you see a very quiet eye immediate post-operatively. Some summary points, and I'll show you one tricky case after this is suture the wounds, you have peritomy, then you place a trocar for infusion or getting the eyeball taut. Fashion out your scleral flaps 2 by 2 millimeters. Use a sclerotomy 0.75 millimeters. Anterior vitrectomy is then done, and externalize the haptics using the handshake technique. Tuck them with using a Gabor chariot standard. Either use a pilocarpine or use some pupilloplasty, whichever deems fit for that case. Close off and see your post-ops always. One special scenario which I wanted to talk about is this case, which has a sommering ring all around. You're basically you're making your flaps before you even do anything. It's an aphakic eye. Patient was 27 years old, probably done. The case was done when he was very, very young. And I'm making a trocar AC maintainer in this case. Once I've got my eyeball taut, I'm making my sclerotomies under the flaps, making sure that it goes under the iris and under the sommering ring. Once that is done, I'm performing my anterior vitrectomy. Now, without disturbing that sommering ring, basically I have to use that 2 millimeter or 3 millimeter optic off the capsule to go in and perform my glued intraocular. That way, this is very forgiving because even a 3 millimeter pupil is more than enough to actually perform the glued IOL part of it. Now, it is for the sommering ring part of it that I really need to expand the pupil and actually visualize what I'm doing here. So what I'm doing here is basically making sure that all my haptics are tucked. Now that gives me a rock solid bed to basically bring out all these sommering ring pieces on top, quadrant by quadrant. So my iris hooks on the other quadrants are all out. Now I can use two techniques. One is a burping technique. So I basically burp these sommering ring pieces because they are honestly just like cataract. They are as thick as cataract. You try and take them with a vitrectomy cutter, you'll be sitting there for 45 minutes just trying to cut and causing more and more inflammation in that eye. The other step which you can do, like in this piece, this was a rather large piece that I had to burp out. You couldn't burp this out even if you wanted to. So you probably have to use a phacoemulsification, and that glued IOL over there acted like a scaffold and did not allow my piece to fall down inside the retina. And that's the big advantage of doing this glued IOL before you actually go ahead and take care of any sommering ring. Once that is done, you basically take off the trocars and put in some glue. And this is the postoperative vision of that patient. This is all I had for you today. I wanted to also thank Sergio and Shin for helping me be here.
Wow, thank you very much. Boy, that was such a beautiful description of a classic technique. Next is Amar, who has been such a mentor for me over the years. There's been times when I've panicked and emailed him and asked him for advice on this technique, and I just can't thank you enough for your support. We are going to go into maybe some more complex cases with Amar and the same technique. Thank you.
Thank you very much, Tom, for your lovely, kind words. I'll just share my screen for a minute and let me know if my video is playing.
Yes, great, Amar.
Okay. So basically, if you see this video, you notice, first of all, this patient has got pseudophakic bullous keratopathy. But look at that. The cornea is white. Now I'm making my scleral flaps. I'm making a scleral tunnel because I can see there is an AC IOL inside that eye. I cannot see anything. So I thought I'll take off the epithelium, which is so hypertrophic there, to see something slightly better. Now, always have fluid in the eye. As Ashwin showed, either a trocar AC maintainer or a trocar infusion cannula. Now, if your flaps are not 180 degrees, I see that I make them 180 degrees. Now I'm making my sclerotomy, and I always do a posterior vitrectomy because in this case, I do not know whether the surgeon has dropped a nucleus, IOL, anything could be inside. So I do a posterior vitrectomy, and even through this hazy cornea, you can still do it. Now what? The next step is I made my scleral tunnel incision, and my problem is to take out this IOL. these IOLs get entrapped into the iris. So you have to be careful when you remove them, because they can either produce an iridodialysis while removal, or they can produce a bleed. The IOL has come broken, but does not matter. Now I'm taking off one more haptic there, and you can see there's a third haptic coming out, but still I have one more haptic which is lodged onto the iridectomy there. I'm trying to remove it slowly and carefully, and remember, during this procedure, my fluid is still on. Still, with this difficulty, still I've got a bleed, but touch wood, it's not much. So now my next step is to take the lens inside. Since I already have a large incision, I can just push it like a non-foldable IOL, catch the first haptic inside, externalized it. Now I do the handshake technique. So watch it, I'm transferring the haptic from one hand to the other, catching it. Now my first IOL forceps goes inside through the sclerotomy, catches the second haptic there on the tip, and externalizes. And as Ashwin said, even through a small pupil, you can still do it very well. Now we move to Gabos tunnel there, and I've taken a 26 gauge needle. Look at the amount of haptic externalized. That is the key. If you do not have enough haptic externalized, please come more anterior. In which case you might have to do a small iridectomy also, so that you don't damage the iris. But in this case, I've got enough haptic externalized to tuck into Gabos tunnel there. So once I've got it inside, now look at my pupil. I need to make this slightly smaller. So Ashwin talked about this, but just to recap on this, we do the single pass 4th row pupiloplasty. On one side, just going through a straight 10-0 or 9-0 Proli needle suture that goes through clear cornea. On the other side, remember, you have a paracentesis. So remember, paracentesis is needed only on one side, where you're going to bring the loop out. Now I pass a 30 gauge needle through that into the iris, railroad the two, bring the suture out. Now I brought this first loop out. So this is the single pass. Now remember the number 4. Just pass it 4 times, and that is game, set, and match. Normally you do 3-2-2 or something like 2-2-2 or whatever you want. Here you have just done 4 times and it's over. That's it. So it's a very simple procedure which anyone can do. Here you can see through the clear cornea, I passed the needle, brought it out. Now I bring that loop out. That's the loop out. And look at my assistant is using an endo-illuminator from outside so that I can see better. Remember the number 4. So why 4? Because if you do 3, it will open. 5 does not open, but 4 also does not open. So you don't need 5. So the simple procedure is 4, and that's it. You don't need anything more. It's a simple procedure which anyone can do. Now, once I have done that, why have I done this? Look what I've done. Air will remain in the eye. 2, any closed angle will become an open angle. 3, any astigmatism is gone because I made it like a pinhole pupil. So these 3 procedures help the solution die. Now I take the endothelium. Look, you're looking at the eye, you're looking at the endothelium from the top. We only do PDEC, we don't do DMEX, because please understand, when you do DMEX, your donors are above 50. You cannot strip off the endothelium in donors unless the donor is about 40 or 50 years of age. In DSEC, it's too thick. PDEC has advantages of both DMEC and DSEC. So here you see we are creating a bubble. How do you create this bubble? That's the bubble is created. This is a type 1 bubble. And we started this technique with the help of, in collaboration with Harminder Dua also. Look at the bubble. It does not go to the periphery. So where is the air? You have endothelium, you have desmase, then you have the Dua's layer, then the air. That's the PDEC bubble. If it went to the periphery, you would create a DMEC graft. I enter into this with a knife, stain it, and once I've stained it, all I do is dissect it. Those who want eye banks in America, you just have to call them up and tell them to give you a PDEC graft, because Ashwin has shown them how to prepare it. Only question is, please go for donors below 40. We never touch donors above 35 or 40. Once I have done this graft ready, all I need to do is create another trocar for air. So I've got one trocar in the back for fluid, one trocar in the front pushing me air. So all I have to do is take off my bad desmase endothelium complex. So I'm taking this off, as you can strip it off just like you normally do in any endothelial keratoplasty. Once you have done that, take your graft, load it in any technique, whichever you want, because it works like a DMEC graft, and inject it inside. Again, unrolling a PDEC is extremely easy. You can manipulate it. A DMEC graft will tear. In this, it will not tear. So I've just unrolled it, put in air. This is an air pump assisted PDEC. I've got air continuously flowing inside the eye. See how I can move the graft. You can't do that in a DMEC graft. In this, I can center my graft, apply the glue, seal everything down. Now the question comes at the end of the day, how did this patient behave? So let's see at the end of the day, when the case is completed, how this patient behaved. So you are seeing now intraoperatively on table how the case looks. Now we move to the next step. Look at the patient. 2 weeks post-op, how the patient is. 1 month post-op. 2 months post-op, look at the patient, has improved to 6/9 vision. 3 months post-op, and compare it to the pre-op, you'll see. And look at the final picture, ladies and gentlemen. You have the pre-op, you can't even see the IOL, and look at the post-op. And that's the beauty of the PDEC procedure. So here we have done a glued IOL, then we did explantation of the IOL. Before that, we did the vitrectomy, we did the orthopuplasty, and finally ended it with PDEC. So I'd like to stop sharing the screen and hand it over to Tom and to Gerardo.
Incredible, Amar, incredible as usual. Well, we continue now with the great Jim Yamane. Jim, I'm the president of the fan club Yamane in Argentina. Did you know it? Okay.
Yeah, thank you.
Let's go, Jim.
Thank you for listening this course. My talk is about Yamane technique.
Jim,
the video is not a,
no.
There's not the video, only Japanese language here.
Yeah.
Shin, you'll have to share the presentation, the video application, not the folder. You're sharing the folder right now. After opening the video, pause it and then share that application particularly.
Perfect.
Okay.
Yes.
My talk is about Yamane technique. Exposures. Today, I'd like to show you my personal tips of Yamane technique. I first inject OVD and make PI, papillary using Moderator. I do not dilate the pupil before surgery. PI, I performed subtenon anesthesia because the anesthesia induced pupil dilation. After vitrectomy, I removed the dislocated IOL using Fukuoka technique. Maybe Dr. Fukuoka will tell us the detail of this technique. I set needle stabilizer and make 2 scleral toenails using 30-gauge thin-wall needles. The scleral toenails were made 2 millimeters from the limbus. In this moment, I aligned the IOP to 40 millimeters mercury. Then I inserted the IOL on the iris. The main wound was made 70 degrees from the left scleral toenail. I pulled the IOL upward to make easy to grasp the leading haptic. I grasped 2 millimeters from the tip of the leading haptic and inserted into the needle about half of the haptic. I grasped 2 millimeters from the trailing haptic and insert into the needle. In this moment, I twisted left hand to make the direction of the trailing haptic goes downward to insert into the needle. Then the haptics were externalized with the needles. I externalized one side and grasped and pushed back, then externalized the another side. This maneuver is necessary to avoid slippage of the haptic, and I confirmed the tilt of the IOL by watching the reflection of the cornea and IOL. Then the haptics were trimmed and dry up and making flange. My flange was coming smaller compared to 3 years ago, and the flanges are fixed completely inside the scleral tunnel. Finally, I removed trocar cannulas for vitrectomy. And adjusted IOP. There are many tips of the Yamane technique. Please find your personal tips for mastering this technique.
Wow, thank you so much for that. Our next speaker, and let me just mention that we're going to have discussion at the end. So we're saving our discussion for the end, just so you understand. And we have some exciting discussion, including a bonus video by Chishiko, who's going to tell us a really cool thing. So that's a little teaser for the end. But for right now, we're going to have Brian Kim, who Dr. Yamane mentioned some variations of the technique. And Brian Kim has got some really cool variations on YouTube and other media that I have followed. And so I'm really excited to have Brian talk to us about his modifications to this technique.
Brian is the master in this technique, right?
Oh, I am still a pupil under Dr. Yamane. Well, thank you. Can you guys hear me?
Yes.
All right, great. Well, Dr. Oeding, thank you for that nice invitation and introduction. I've been watching you for years, even as a resident, and in all your teaching videos. So thank you from afar for teaching me cataract surgery and all these complicated techniques. Thanks to Ashvin, Sergio, and Shin for having me. Obviously, I'm following Obi-Wan Kenobi of Yamane technique. And so I'm not going to be able to do anything more than what he does, but hopefully for the learning surgeons, I can help break down kind of the complexities of this technique. So I have no financial interests. So imagine this case. You are learning scleral fixated techniques and you have this aphakic patient who needs a secondary IOL, but the problem is this patient is anuritic as well. And so you're wanting to choose the Yamane scleral fixation technique, but there are some challenges. So number one, the leading haptic is usually placed on top of the iris when you deliver the optic. but this patient does not have any iris to support the leading haptic. Secondly, when the leading haptic is fixated into the left side needle, the trailing haptic can be difficult to cannulate the right side needle. And so this is the solution that I came up with to make things easier for me. And this is a trailing haptic first modification, which was published in 2018. And essentially, you want to externalize the leading haptic through a contralateral limbal incision, and this secures the IOL from descending into the vitreous space, but this also improves access to the trailing haptic for needle fixation. There are a few other things I want to discuss here. So accurate scleral needle placement. So, we're marking the conjunctiva, but the conjunctiva is a mobile structure. And so if you're not careful, your markings and where you want to actually place the needle through the sclera will not be the same. And therefore you can have tilt and other issues. And secondly, that if the eye is soft, it's very difficult to cannulate and it causes the globe to collapse. And so the solution has been stated before by all the other excellent speakers is that you need to have continuous infusion. You need a firm globe to pass the needle through the sclera. And I use a Lewicki 20 gauge. I used to use a 23 gauge, and I'm using a 20 now. And that's just to increase that volume. You want to hold the conjunctiva in the neutral position for scleral needle placement so that your conjunctival marks actually reflect the scleral needle placement. And lastly, proper scleral tunnel is very important to have a nice scleral platform to minimize tilt. Unfortunately, I've seen many surgeons just dive in through the needle, through the sclera. And if you don't have a nice scleral shelf or platform, that's what leads to tilt and poor lens placement. And so this is just a video quickly showing what I'm referring to. The trocar is held with forceps to stabilize the eye. You can see that the conjunctival marks are not distorted with the needle pass. On the left side here, I'm holding the limbus with the forceps and doing the same maneuver. Again, you're wanting the conjunctiva to reflect the scleral needle placement. Docking the haptic on the needle. So the haptic is curved and the needle is straight. And this is why people can struggle to cannulate the haptic through the needle. And so the solution is to dock the haptic on the bevel of the needle first, but don't advance it yet because you have to straighten the haptic against the bevel and then it should slide easily into the needle. And you never want to force the haptic into the needle when it's not straight. The haptic must face the bevel of the needle to facilitate the docking. And so the left side needle is facing away from you, the right side towards you, but it's always facing the haptic. So here is the video. The bevel is up, the bevel is towards you, the bevel is down, and it's difficult to cannulate. And this is because the needle is straight, but the haptic is curved. You want to dock the haptic towards the bevel, which is away from you, straighten the haptic, and then you can advance the haptic. So why do people talk about this trailing haptic being a problem? And I was thinking about this, and it was hard to articulate until I realized it's actually called, I'm calling it the tug of war effect. And so what do I mean? Once the leading haptic is fixed to the left side needle, the trailing haptic needs to be pulled towards the left to straighten and thread the trailing haptic into the right side needle. But there is a tug of war effect because the left side needle haptic complex resists the straightening of the trailing haptic. And so you will see that here. It's very difficult to control the haptic when you're holding it too far, and that's number one. But also the left haptic is tethered to the left needle, so it's harder to thread the right haptic. And this is a problem with the trailing haptic. And so this really encapsulates everything I'm referring to. The technician advances the IOL and the surgeon externalizes the leading haptic through the microforceps, through the limbal incision. The trailing haptic is captured into the incision in a U-shaped configuration. The apex of the U is the ideal place to grasp the haptic. Note the bevel of the needle is facing the haptic. You straighten the haptic and then tunnel through. The leading haptic is internalized. In this case, you could, I'm putting it on the iris, but you don't have to. You can try to do all the maneuvers together. So the leading haptic is tethered in the same exact way, again, flattening the haptic and then straightening through the needle. And then, of course, you want to pull each haptic out. And this is the end of the case here. So in summary, Dr. Shin Yamane really developed an innovative and elegant scleral fixated technique, but there are some technical challenges for the learning surgeon, and I do believe these modifications help to flatten and kind of articulate and explain what's going on. And I hope this was helpful to you, and if you have any questions, happy to field them. Thank you again for having me.
Okay, great idea, Brian. Really great. Well, we continue with the master Sergio Canabrava. I present you in Spanish, in Portuguese, or in English. Sergio is a friend. He has
in French. In French. Let's talk in French.
I just speak a little in English. Sergio is my friend. He has great ideas, and well, show you one of these ideas, please.
Thank you, Gerardo. It's a pleasure. Let's start. Today Can you listen to me?
Yes, man.
Yes, let's go. Today I will talk about the Canabrava four-flanged technique pures. Here my disclosure. Today I will talk four-flanged polypropylene test 6050 polypropylene, which IOL should you use in flanged size. Every all my talks, I say thanks for Yamane to publish this flanged because he opened doors for everybody. And let's talk first about the double flanged tests late of 2017 with adjustable polypropylene. Here, scleral simulation test to see how the flanged in polypropylene stays stable. Here, a breaking test. As you can see, how the 6 and the 50 polypropylene is stable and the polypropylene haptic break and the flanged not break. And here, I'm honored because this double flanged, many surgeons around the world use this double flanged concept that nobody is stay talking about it between 2017 and 2019. And it's an honor for me to open this door. And today I will show the pures about the no foldable Canabrava technique and the foldable Canabrava technique. 6050, I suggest for no foldable IOL 50 and 26 gauge needle. And for foldable IOL, I like to use for eyelets IOL 29 gauge with large lumen and 60 polypropylene suture. This is important point to show in the pures of the technique. Which IOL should I use? And in no-foldable IOL, use a traditional Lewis and Malbran IOL for the technique. And for eyelets IOL, we have many in the world. Acros IOL, that was the IOL that I started to publish the technique because the one IOL that you have in Brazil. But you have Micropur from Physio, is hydrophobic IOL, hydrophobic. Artis from Crystalline France, hydrophobic too. And Mini 4 often is for eyelet too. You have happened IOL in Russia too. Okay, no foldable insertion, the first pill is important. Observe in this video, you need to insert the IOL first. You need to do a scleral tunnel. I don't like to do a corneal tunnel because a large incision. And you do a scleral tunnel and insert it in the sulcus. It's important to insert the IOL in the sulcus. And look, my left hand, I pull the polypropylene, and then a pronation movement. And now you can see how the IOL in the sulcus in a good position. And observe the 50 polypropylene. 150 polypropylene in one side and another in another opposite side, because you need to create a long tunnel like in Yamane technique. Previous polypropylene test and needle angulation. Observe, it's important to test the 6 or the 50 polypropylene inside the needle before to start, and important to mark the position of the the scleral tunnel. And observe now, the angulation is so important. You need to do a long tunnel to do this technique. Okay, flanged side. The right side, you have the bad size. Every surgeon, including me, when we start the technique, we start with a large flange. It's not good. You can have endophthalmitis, conjunctival erosion. Then the left side, you can see the right side. If you have a long tunnel, you don't be afraid. This tunnel, this flange, it will be great. Then right side is not good. You can produce many complications. If, for example, in my first paper about the four eyelets IOL, that you can see endophthalmitis, conjunctival erosion and inflammation that I treated with 7 days with moxifloxacin and corticoids, and after 7 days, I back to the operating room and reduce the flange inside it again in the right side. Guys, thank you for the attention, and thank you all speakers. For me, Shin and Ashvin, it's an honor. The creme of the la creme of the scleral fixation in the world with us today. Thank you.
Thank you, Sergio. That is such a great modification of Yamini's modification of the haptic. It's so crazy how now we've found so many ways to use Proline, and you're sort of the leader of the band. And so we're going to now move to Carlo, who's got an artificial lens, which borrows from some of these ideas or pushes these ideas forward. And look forward to your presentation, Carlo. Thank you.
Thank you, Thomas. Okay. Thank you, Dr. Ashvin. And hello, everybody. On 2000, can you hear me?
Yes.
Okay. Okay.
But
on 2012, I had an idea. Why don't put a T-shaped plug on a closed haptic of...
Carlo.
Yes?
Carlos, sorry, we can't see your screen, only your voice, okay?
Yes, I know. Okay, so it's fine. It's fine at the moment.
Okay.
And why? Just to put, why don't put a T-shaped plug on a closed haptic of a foldable lens in order to avoid to use suture to fixate the lens to the sulcus. And since from the beginning, the lens worked quite well, that's why after 2 years, on 2014, I presented the first report of the first 9 cases to the European Congress of Cataract and Refractive Surgery. Which is important. There is a very good paper of Takeshi Sujura that shows how is the thickness of the sclera just in front of the ciliary sulcus. You may see that the thickness ranges between 1.5 till 2 millimeters only. And if you can see my plug is, the thickness of my plug is just 0.3 millimeters. Then on the right side, you may see the sclera, some anterior segment OCT, and you can see how is the plug buried in the sclera. There are no sign of deformation of the sclera, and no sign of irritation or decubitation.
Carlo, are you sharing a screen right now or no?
Yes.
Oh, it's not shown here, that's why. We're not seeing anything.
But you can see can you see?
No.
No, no.
No.
We can't see it.
Okay.
You need to start sharing. It's a green button in the down part.
Keep the presentation open and press the green button and then share that application.
Share screen.
Just a moment. Where I am? No.
No. Is your presentation open?
Yes.
Just leave it open. Come to Zoom and press the share screen.
Share, maybe share.
Yes.
Now?
Yes. Something is open. Let me just, can you go to the PPT?
Okay.
I'll just click that.
Here?
Yeah, click.
New share.
Can you cut Zoom out? I mean, just cross this Zoom.
Now?
Yeah, perfect. Now just press the presenter view, please, on the bottom, bottom right.
Here, okay.
Bottom right button, the presenter view.
Okay, can I go ahead like that?
Okay, that's fine. But
it's fine?
If you can press presenter view, which is on the right bottom, there's a...
Here?
Yes, perfect.
Okay, okay.
Yes.
Let's go ahead. A part of this is an experimental video. You can see how the plug works. Once you grab with your micro vitrectomy forceps, the plug, the two wings of the plug bends like an arrow, then go through the thickness of the sclera and opens on the other side and stabilizes the lens to the ciliary sulcus. But this lens has different other features. I want to show you, how big is the loop. Such a big loop works like a wing, stays in the ciliary sulcus and stabilizes the lens. So this lens has a very good three-dimensional stability because the lens cannot tilt along the axis between the two T-shaped plug. And then another thing, you may see there are some notches here in the arms. They are connecting the loop and the optic disc, and this notch may allow to the lens to be adapted to different diameter of ciliary sulcus without modification of the distance between the optic disc and the cornea. So the effective lens position remain fixed. So this lens has a very good refractive predictability. Let's see how it works. Just opposite 180 degrees opposite scleral flaps, 4x4, perforate at 1.5 on the bed of the scleral pocket. Then you grab the plug with the forceps and you externalized the plug of the leading optic. You have to do with your microforceps the same thing with the trailing optic. And once the plug is externalized, open and stabilizes the lens without any suture. Special recommendation: 2 curved, no teeth microcoaxial forceps, because if you have a deep set eye or if you have a big nose, it will be very difficult for you to handle the T-shaped plug. Always try the forceps in the scleral hole before inserting the IOL. Always engage the plug before inserting the IOL in the anterior chamber. Otherwise, you may drop the lens in the vitreous. Always sculpt a wide scleral flap to avoid late decubitation of the plug. Suture carefully the conjunctiva. This is a follow-up of 8 years. You may see the anterior segment OCT and some photo, slit and photo. There are no deformation of the sclera, no sign of the decubitation. 2 years late, I changed the technique. Now I'm doing 2 radial cutting opposite 180 degrees, 2 small scleral pockets on the 2 sides of the 2 scleral cutting. Then I perforate at 1.5 millimeters from the limbus. I insert the forceps. The procedure now is the same. You hold the plug and progressively you insert the IOL in the anterior chamber. At the same time, you externalize the T-shaped plug with of the leading optic. The same thing we have to do with the trailing optic. Now the plug is on the sclera. With the forceps, you have to bury it in the small pockets you have previously realized. Then you may put a small stitch on the conjunctiva. That's it. This is a follow-up at 1 year. You may see the plug here on the conjunctiva, and this is the same patient. You can see how is buried the plug deep in the sclera. There is another way to use this lens. This is a luxation of complex bag IOL. What I've done, I put viscoelastic behind the first lens and the vitreous. I have inserted the lens behind the vitreous, the second lens behind the vitreous and the first bag and IOL. Then here, in this case, I made a mistake. I could not externalize properly the plug of the leading optic. So the plug of the optic is still behind the iris root. What I've done, I have started to fixate the plug of the trailing optic. So at least 1/2 of the lens is stabilized to the sclera in the ciliary sulcus. Then I have removed the complex of a bag luxated IOL. And then I've tried to identify behind the iris the plug of the leading optic. Once you can see the plug of the leading optic, the procedure is almost ended, finished. I have done 3 patients, always with the same procedure, luxated lens. In all these 3 cases, I have explanted 1 lens. I have implanted a scleral fixation lens without any movement of the vitreous. Thank you for your attention. Thank you to Ashwin for the invitation.
Hey, thank you, Carlo. That was wonderful. I really appreciate you sharing that innovative lens design and your great experience with that. Well, I just want to tell you we've done a great job getting through our cases, and now we've got a few minutes where we want to discuss. We've got a lot to talk about. There's a lot of really interesting things to discuss. But we want to start off with our very patient panelist who's waited all this time. And now we can hear from her, Shashiko, who's going to start off with a video. And then I'd like you to maybe comment on some of the cases if you could. Thank you.
Fukuko, your video.
Okay.
Right.
I will show you the video of cartridge pull-through technique. Clean the vitreous body around the IOL. A sclerocorneal incision is created. Adjust the position of the IOL. OVD is filled inside the cartridge. Set the forceps to the cartridge. The forceps are inserted into the anterior chamber to grasp the IOL optic. Push the cartridge into the anterior chamber from the wound. Pull out the forceps from the cartridge. The cartridge and the forceps are pulled out of the anterior chamber together. Next case is extraction of a single-piece IOL. Next case is extraction of hydrophilic IOL. The tools used this time are Hoya cartridge and Fukuoka's IOL extraction forceps. We believe that the cartridge pull-through technique is a minimally invasive IOL extraction surgery.
Great video, great video. You need to cut the cartridge at the front, or it's not necessary?
I think Hoya D1 cartridge is best, but this cartridge currently difficult to obtain. So use instead of D1 cartridge, C1 cartridge of Hoya or 2C cartridge of needed. And Monarch A of Alcon cannot use because this cartridge is too long. Tip of the forceps cannot appear from the cartridge.
Do you always make slit to the cartridge?
So if you think the cartridge is thin, so you have to cut it better.
One more question. How big is how long is the tip of your forceps? The head of your saw or your forceps. How long it is?
It's a shaft.
The length of the tip.
Yes,
of the forceps.
The length of the tip of the forceps. Yes.
4 millimeters.
I don't know the detail, but the Monarch A cartridge is too long and can't use.
Because if you have a small head, you will not able to pull it inside.
Yeah.
But works anyway. Right. Works, so the length is enough.
We need to buy your forceps, or we can use another kind of forceps.
So I designed this forceps, and so forceps for overseas are currently being prepared just now.
Can we use another forceps, like forceps for DTEC or something? Another choice of forceps?
Or the ICL forceps, I don't know.
I tried to the vitreous forceps, vitreous surgery forceps, 23 gauge or something like that. It is really fine, and they break the IOL, and we can't use.
Okay. Okay, thank you. Great technique.
Thank you so much.
Tom?
Yeah, I wanted to talk a little bit about, there's a lot of people that are probably watching that are wondering, how can I get started? Because I think one of the things that's interesting about techniques like this is the transition that is difficult for people to do. And I think, it's one thing for really bold surgeons like Amar to try techniques like this, but for a lot of people, they need a stepwise transition. And I just wanted to show this one little video just to emphasize how easy it is to use simulated eyes. And so this is just a Craig Phillips simulated eye. There's a bunch of different models, but it just shows that even a relatively complex technique with sclera manipulation can be simulated with these eyes. This is a Craig Phillips eyes. All the basic issues of Dr. Agarwal's technique can easily be simulated with this particular eye. You certainly can do the same thing with Dr. Yamani's technique, with Brian Kim's modifications of that technique. He showed you some simuli eyes. So I just wanted to emphasize that, for a lot of folks, I think it's going to be tricky to change and to try these techniques. And so one of the things we learned during COVID when all of our ORs were shut down was that we could use our OR, bring these simulated eyes into the OR and practice. You don't have to have a fancy wet lab. You can use your own OR. You can use these artificial eyes which have no cadaver or animal products, and you can try these techniques. And I think it's a nice transition. You watch the videos, you try them on these simulated eyes, and then I think the third step to do transitions, if you're not as bold as Dr. Agarwal and others here, is to bring somebody with you for those first cases. So if your very first case, bring somebody else that's familiar with the anterior segment. Neither one of you have to have done the case before, but if both of you have some skills and in other areas of anterior segment, it's very nice to have two people there, four hands when you're doing these cases for the first time. So I just wanted to emphasize that. Does anybody else have any tips on getting started? Because remember, a lot of people that are watching may be nervous about getting started. So any other tips anybody else has?
I think Brian should go first. Brian, what do you say?
Well, I agree 100%. And Tom brings a great point about bringing artificial eyes, so you don't have the pressure of, potentially harming a patient. I think a stepwise approach is exactly my story. When I did a cornea fellowship and graduated, you have some basic skills as far as suturing and manipulating in the anterior segment. But, a lot of these techniques I learned after the fact. So I think for me, suturing iris was one thing I started to learn. And then at the time when iris suturing of IOLs were kind of more popular, I learned that technique. And then learning how to do pars plana vitrectomy as well. And I think with each component, you're able to learn the next step. So, being able to do the railroad suturing in an aerodialysis situation, through pupilloplasty, glued IOL, doing even like learning how to do trabs and doing scleral flaps, I think help you with doing the glued IOL technique. And I think learning a variety of techniques will kind of build your overall armamentarium. And then even though techniques become new, you will have had some level of experience with those types of maneuvers. And I think that is very important. Even knowing how to position yourself at the head of the patient, more temporal, more superior, being aware of various ergonomic issues that go on, I think do help step by step. So I think you can't just jump into the deep end of the pool. You have to tiptoe and do kind of a sequential approach, as Dr. Edding said as well.
Okay. And for the panel, what about the material of the haptics? I use, and I recommend for the beginners, PVDF haptics. What is your experience about it?
I think the PVDF haptics are fantastic. I just feel that the availability across the world is very, very low. So that's a big issue with PVDF haptics. So you have to make do with something else. And that's where all the other techniques kind of come into play. One. Second is also, I feel that Yamane technique is fabulous in its own way, but there are some limitations to it, and that's where you really need to have something secondary in your armamentarium or in your hand to actually go ahead and implant and lens in those cases. And that's where the other techniques also open up a whole new channel. Having said that, I'd love to hear a few comments for beginner surgeons from Sergio. Why not? Sergio, you're teaching a lot of young surgeons as well as young medical students. So go ahead, if you have any tips for younger surgeons.
I think the more important is start with wet lab and know everything about the technique you will try to perform. I saw some surgeons only looking the video on YouTube and want to start it. I think it's a great error, and it can produce a damage for your patient. Then my big suggestion is start in wet lab, start step by step, study the technique, study the tips, the peers, before to go to the live surgery with your patient.
Right. Carlo,
I agree. Absolutely.
You have a great IOL, but some physicians say something about the material. How it works with silicone oil? It's okay? Carlo?
Yes.
You hear?
Yes. Tell me.
Some physicians say something about the material of your IOL. That's it's not good for use when you make a vitrectomy with silicone oil. Is that true?
Yes, it's true. But I mean, now they are starting now on the market different other materials. They are more. This lens starts to be as hydrophilic.
Yes.
Okay. A part of the silicone oil, there are no any problem because PC opacification does not affect this patient.
No. Yeah, you're right.
Without capsule. Second, I mean, I had 3 cases with recorded with the retinal detachment and silicone oil. There are small droplets on the posterior surface of the lens, but the visual acuity is absolutely perfect. But anyway, now the material is starting to change in a hydrophobic. There are some problem of stiffness. I mean, is more difficult to handle.
Yes.
But I mean, we are starting new material now.
Okay.
Hydrophobic.
Okay. Perfect. Great.
But on the other hand, you have many advantages. Is still elastic. Even if you pull it a lot, you will not break it. With a 3-piece lens, if you pull it, you break the lens. Absolutely. You break the optic. Absolutely.
You're right. What's the best technique for aphakia solved? Okay, Tom.
Wow, that's the perfect question.
Go directly in the jugular.
Hey, I wanted to ask you for any of these cases that we just discussed, you can sometimes get exposure of the haptic, and so I've had or possibly exposure of the suture. So in my experience, this is very rare, and what we've done is we've typically used tissue glue with either sclera or tutoplast or something like that, and just put it over the top. So I want to hear what other people are doing in that situation, in that rare situation where you have exposure of either the proline suture or the haptic. How about Dr. Yamini? What is your, maybe this never happens to you, but what is your approach?
So you mean how to avoid exposure of flange?
Well, I mean, if it becomes exposed, what do you do?
Yes, it's very rare, but if the flange exposed from the scleral toenail, I enlarge the scleral toenail using needle or some knives and push the flange into the sclera.
Do you put anything on top of that, like tutoplast or cornea or sclera, or you just tuck it in?
Sorry?
Do you put any other material on top of that, like additional sclera or additional corneal tissue or tutoplast?
No, just push the flange into the sclera. If I push if I fix the flange completely inside the sclera in the first surgery, it never moved to outward. So if you don't fix the flange, if you leave the flange on the sclera, it will move. So you must push the flange completely inside the sclera.
Okay.
I have no case with melting of the sclera.
Yes. I make 2 pockets. Usually, I make a little modification in the Yamane's original technique, but with the 2 pockets, the haptics go every time into the sclera. They don't go out. Ashwin.
I like to hear about the master, Dr. Amar, your consideration for the young surgeons.
Basically, when you have an exposure of the haptic, it basically, if you are doing an occludal or any technique like this, it means basically that you have not tucked the haptic inside, you've done it partial thickness or into the conjunctival area. That's the main reason why it comes out. What you do is I take the patient back to the OR, lift the flap, make a deeper pocket tunnel inside and tuck the haptics inside. The second reason why an haptic exposure can happen is if you don't have enough haptic exposed to tuck inside. So there's very little which has just come out of it. So in which case you might have to come more anteriorly. That's why I said, look at the amount of haptic which is exposed. There should be a lot of haptic which can be going inside the Gaucher-Ayres tunnel, because if you don't have enough, then the tilt will happen. One final thing is we have just published in the JCRS, it's coming out, it's online now, a 12-year study of the glued IOLs. And what we are seeing in that is a 1 degree tilt, less than 1 degree tilt, which is after 12 years I'm talking about, which shows an extreme amount of stability of these lenses, intrasternal haptic fixated lenses, even after 12 years.
Okay, my friends, we take a lot of time. Ashwin, words for close the session.
Yeah. Thank you so much, everybody, for being a part of this event. It's been absolutely stunning to organize it for all the audience, and having each and every one of you, getting to know you guys so much more, deeper, better. It's always been a pleasure. I have to thank my internal team and Sergio's team to actually help out organizing this event. I also must thank Shin and Sergio to actually help me pull off something like this, because honestly speaking, it's all on their shoulders. I have done nothing but just crawl up and be on their shoulders. We are closing this course, all right, but I wanted to also lean in to each of your ears and also bring you up to speed that April 10th and the 17th, we will be having the World Webinar on Cataract and Refractive, and it's a 2-day affair spread over 2 Saturdays. Our website should be up in the next month or so, but we're going to have a lot of good sessions over there as well. Would love to see you there. The World Webinar 2021 edition will be live and kicking, but nonetheless, World Aphakia course will also run as an annual event. But this has been absolutely brilliant. Thank you so much for being here. Shin and Sergio, if you could also comment in a few words and give your goodbyes.
No, you the chief, you the boss, you are always come and defend. But Don, Carlo, Sachiko, Gerardo, Amar, Brian, thank you.
Everybody. Thank you, everybody.
Everybody.
Thank you. Bye-bye. Bye-bye.
Merry Christmas. Happy New Year.
Bye-bye, everybody. Bye-bye.
Bye-bye. Thank you.
Bye.
Again.
Bye.